All right, I just want to thank everyone for coming today. My name is Casey Phillips. I'm the lead pharmacist with the Antimicrobial Stewardship Program here in Regina. And today we're going to be doing a presentation on a number of topics focusing on, of course, antimicrobial resistance and stewardship. And I'm hoping to make this a little bit more of a presentation to fit an audience that works in primary healthcare. So for family physicians, nurse practitioners, and even our ER doctors and ER nurses to see this presentation, because it goes over some things that you'll commonly see in your day-to-day practice. So what we're going to do today is just quickly go over again what is antimicrobial stewardship for anyone who's new to it. We're going to discuss how in our program we've been trying to connect with the community, and when I say community, I mean community prescribers. So again, the vast majority being family physicians, but also nurse practitioners, also dentists, also pharmacists now. So reaching out to that broader audience. We're going to look at a bit of the evidence for shorter duration of antibiotic courses and treatment duration specifically we're going to look at just one indication, acute bacterial rhinosinusitis. Then we're going to take that data from what we are seeing that we should be doing it and look at some of the clinics here in Regina to see how they've been doing in regards to keeping up with guidelines. And then finally, we're just going to go over a few tools that community prescribers can utilize to help them in their practice. And finally, where do we go from here? So what are the next steps for us? So what is antimicrobial stewardship? First off, it's looking at, is an antibiotic necessary? So if there's no clear indication for that antibiotic, the patient shouldn't be getting an antibiotic. And the most common scenario that we see here is viral illness. And many antibiotics are prescribed for that. From there, if you do know that, I believe this patient has a bacterial illness that I can treat, from there you look at what is the best drug for that patient, what is the best dose for that particular indication, how long should we treat, and what is the right route. More of an issue in the hospital where we have easier access to IV versus oral options. But it's also important to note what antimicrobial stewardship isn't, and we just want to be clear, it's not about policing, shaming people, or eliminating prescriber autonomy. And I think that's one of the biggest questions we had when we started is, are you guys going in there and cracking down on people? And it's no, we're looking at what people are doing, but we need to, in this program, we need to work together with individuals to help support them and optimize what they're doing. And that's exactly what it is. It's about creating a collaborative effort among healthcare professionals for best practices and for us all knowing what our place is in this initiative. So the question came up really, where do we start from here? And we know that antimicrobial resistance is a problem everywhere. And, there's even, we can look globally and, across the world, there's even the One Health approach where we're looking at antimicrobial resistance is a problem everywhere. It's a problem in human healthcare. It's a problem in veterinary medicine. It's a problem in agriculture. How do we all work together so that we're all working on the problem? Because it's not just one part that's driving it, it's the whole piece, right? So where do we start from there? And traditionally, most antimicrobial stewardship programs are all in the hospital. And part of the reasoning for that is there's a number of reasons, but that's usually where you have more of your resources with your ID physicians, microbiologists. You have more of your clinical hospital pharmacists to drive that. And we just haven't had those same supports in the community. And so there's always been sort of a bigger research push. There's a lot that can be seen what's happening in the hospital to help with this, but there's not research out there about what's happening in the community. And we decided with that, well, maybe this is one area we should look. And as we started to dig into that more, we could really see that, from national data, approximately 92% of antimicrobials are prescribed outside of the hospital or in the community, right? So, as far as looking at where the bulk of our antimicrobial prescriptions are and where that resistance is developing and where we likely have, inappropriate or, suboptimal use, we can really focus on that area. And that's why it brings us to the piece. It's important for stewardship programs to also engage with community-based prescribers, going beyond the walls of your hospital, getting out in the community to support our physicians there. And an important piece for why this is really important in Saskatchewan, it's important everywhere, but where we see we're sitting in Saskatchewan, and does this thing work? No, my marker doesn't work. Okay, I tried being fancy here. Let's give it a little... Oh, maybe not. Okay. But in Saskatchewan, when, again, we look at national data and how we're doing, based on the number of people who live in the province, who's prescribing the most antibiotics. As you'll see, the third column from the left, that's the Saskatchewan column. So in Canada, the second highest prescribers of community-based antibiotics. So we definitely have a lot of work to do just to even get more in line with seeing in the other provinces, but also figuring out what is driving that likely excess of antimicrobial prescriptions we see. So from there, we decided, let's get involved with these community prescribers. And the first thing we did is we sent out a survey to community-based prescribers, and we included physicians, nurse practitioners, pharmacists, dentists, and veterinarians, just to see what their baseline knowledge was about stewardship, what sort of thoughts they had about it, or if it's something they could see incorporating into their practice. And we use those results to also develop tools to help prescribers out there. And the first one we made was a viral prescription pad, with the rationale being there that if your patient comes in with a viral illness, you can fill out this viral prescription pad that looks and feels like a prescription, but it has more of a plan for that patient on this is how you symptomatically manage those symptoms. Here's how long they may last. And these may be an indication for if you're getting worse and you need to be seen again. These are my follow-up recommendations for you. And we've had a lot of good feedback from, anecdotally from nurse practitioners and physicians in the community who are finding it very helpful, and also in our own emerged departments where we have a similar viral prescription pad. So we decided, let's further connect to the community. And one of the first clinics that really joined on with us, we had Rashad Hanzia. He's a family physician in Regina here. And he really wanted to see more of these things happening in community for physicians. And we teamed up with his clinic to start figuring out, okay, how do we start collecting your data to see how you're doing, what supports would physicians need, and where do we go from there? And for us, besides just, collecting data and feeding that back to them, what we're also hoping to do is develop those tools and supports that prescribers would utilize and that they find useful and handy, but also just keeping on top of the latest evidence for what's happening in the world of antimicrobials. So we're going to go over a little bit of the evidence today, and I hope you guys find this interesting, or maybe I'm just a bit of a science nerd and like reading these things. But there was this great, it's a very short review article by Spellberg called "The New Antibiotic Mantra, Shorter is Better." And what he does is, I like his intro. He kind of gets into how the Roman Emperor Constantine back in 321 decreed that the week would be 7 days long. And somehow, this is almost 1,700 years old, but we've kind of used that as, in the medical world, like 7 weeks is sort of our standard duration for how long do they need antibiotics? 7 weeks. It's sort of this, it's based on a very old idea of how long a week should be, but we've adopted that. So why aren't we using, modern evidence-based methods to determine how long our durations are? Why are we still basing it on this old idea? And really, there's a number of other early studies that drove the early dogma about how antibiotics worked, how infections worked, and how we were supposed to treat them. And one of these was with duration of treatment, where in early studies they wanted to continue past the duration of symptoms by a day or two to ensure that there was no chance of relapse. But when they looked at those studies later, those studies were taken at face value, and that's what practitioners did for a long time. But when those studies were looked at a little bit more thoroughly, when patients had relapses, it was usually a different bug as opposed to the same bug, so longer duration wouldn't have been helping them in that situation. There's also the notion of, how we thought resistance developed, and we always, part of this was always encouraging everyone, stick exactly to that duration of therapy like your doctor told you to. If it's a 14-day duration and you're feeling completely fine at day 6, make sure you keep taking them. And it makes it easier for counseling patients on what they need to do, but it doesn't really align with newer evidence that is finding, even for some, and this is just for specific indications, but if you are feeling better, there are situations where you can safely stop that antibiotic and not continue. And the rationale here is the longer you stay on antibiotics, you're increasing your exposure to that antimicrobial, and you're exposing your microbiome to that antibiotic, and that's where you get the development of resistance. So the sort of stop your pills when symptoms are gone, it's kind of becoming maybe a newer mantra you'll see more in the future. But something we still also have to focus on in the hospital. When can we get our patients off antibiotics sooner?
I don't know all these measures that would...
Well, can I just get you guys to mute your mics, please? I'm getting a little bit of background noise. And just, there's also a very handy table at the end of this article that goes over a number of different indications, from community-acquired pneumonia, pyelonephritis, acute bacterial sinusitis, which we're talking about today, cellulitis, both what we see in the community, in the hospital, and the evidence that's there for the shorter courses of therapy. And, also just keeping up with the latest. We get news from organizations like the CDC in the United States. And there was a recent article in JAMA Internal Medicine that was put together as a research letter by a small group at the CDC. And they were really focused on what sinusitis and the duration of treatment. So they collected data from a number of clinics all across the U.S. For 2016, and it was a random sample. All the patients they had were over 18 years of age, from different services, family, general medicine, somehow pediatrics, even though they have to be 18 years of age, from the ER. And they paired those patients who were receiving a new prescription for an antibiotic that was given in association with an acute sinusitis diagnosis. And they excluded chronic sinusitis or anyone who's on antibiotics for another reason, or they're missing data. And they had over 4 million, or almost 4 million visits in this analysis. And the median duration of therapy they found was 10 days. And roughly 70% of therapies were prescribed for greater or equal to 10 days. And when you took out azithromycin, which is usually just 5 days, then the numbers went up to 91.5%. So pretty much all the time we're using this long duration of treatment. But the problem is, even though we're treating it this way, the IDSA guidelines that came out years before this, in 2012, the IDSA guidelines came out, and so they've had a number of years to get used to a new treatment duration that's suggested of 5 to 7 days. And we can just see this isn't happening. And it's just really the more complicated cases that you need to treat for longer. So their recommendation in this was that, people should be following the IDSA recommendations, which are shorter in duration. And they looked at all the different antibiotics that were used in different regimens, azithromycin being one of them. And that was also identified as a problem, as the IDSA recommends we shouldn't be using azithromycin or macrolides because there's just too much resistance to them. And so from the IDSA guidelines, I liked a couple of their points they had when starting, with their primary goal being let's figure out appropriate first-line antibiotics for patients with a presumptive diagnosis of, and the important part here is in the ABRS, the B for bacterial, acute bacterial rhinosinusitis. So this is really differentiating, you don't treat viral sinusitis. And then the secondary goals, reducing excessive or inappropriate use for viral sinusitis or self-limited bacterial infection, and also working on, coming up with recommendations so that we're not creating more resistance with the treatment we give. And the IDSA guidelines, just the big picture from these ones that I want to focus on is for best practices, picking those patients who likely have a bacterial case versus viral. You're looking at patients who have a longer course than 10 days of symptoms, because viral symptoms will usually be 7 to 10 days. So if their symptoms are persistent, they may need treatment. Or if they have severe symptoms with or without fever, those patients could have treatment right away, or if they have worsening symptoms after upper respiratory tract infection. One of their other points was that macrolides, azithromycin is one of those, used as second-line therapy is really not recommended, again, just because of the resistance that's there. And finally, in section 10, they talk about duration of therapy. And for adults, they're advocating 5 to 7 days of therapy. Still in kids, they are saying 10 or more, because I don't think the evidence is there yet to support that shorter duration in kids. So after reading these articles, though, too, I was kind of wondering, are we missing the picture here, though? Because, the focus of those articles was really duration of therapy and, which antibiotic. But, I want to just bring us back to the point that for the vast majority of acute sinusitis that would be seen in the clinic and other areas, 98% of them are viral. And this is a poster from RX Files, who we paired up with to do some work in community prescribing. And so it's well known that most of these cases are viral and they don't need antimicrobial treatment. And there's just a very small number that would actually need it. And so this, again, goes back to, in stewardship, the first thing we want to say is a drug even necessary? So if it's not necessary, let's just get rid of it. And from there, then we can focus on the finer details. But again, for most of our sinusitis, it's not going to require an antibiotic. And just looking at the Regina area and the antibiogram, this is kind of going back from 2008 up to most recently. So in 2008, strep pneumonia, even at that time, it wasn't great sensitivity. Like we want to see sensitivity to those antibiotics above 90, optimally, right? 80 is not getting great. Below 70, that's when we especially start running into a problem. And you can see, as we go through the years, there was a small blip where we went up in 2016. But, we're sitting less than 70%. We can be sure that azithromycin or our macrolides would actually work for strep pneumoniae. And with this being, that's the main bug we usually want to treat for bacterial sinusitis and different infections. For H. flu and Moraxella, azithromycin should still be okay, but strep is the big problem here. So we decided, let's look at how our clinics are doing in Regina, and we've been very fortunate to pair with 12 clinics in Regina that we call the G12 or Group of 12, and we've been collecting their data on their prescribing. We're also trying to catch the indication if they write an indication for that antibiotic. If we're catching that, we put all that data together, anonymize it, and feed it back to the physicians. And this actually gives them, probably for a lot of them, this is the first time they've been giving some definitive metrics on this is actually what you're prescribing, and this is your comparison to your peers. So for so many people, they're finding they work quite isolated and they're not sure what their colleagues are doing. So this process allows them some comparison that way. And so as we put that data together, we found that, when we looked at using azithromycin or amoxicillin in our Regina clinics versus the Canadian average, in Canada, we see roughly 10% of antimicrobials are azithromycin. And sorry, if anyone has their mics not on mute, can you please mute them? We're getting some background noise here. So in Canada, roughly 10% azithro use and creeping up to 25% for amoxicillin. And that was kind of flipped in our clinics where we saw a lot of azithromycin use and less macrolide or amoxicillin use. And as you can remember, as we're talking about, azithromycin isn't a great one for these infections just because of the resistance. And so we're wondering, why are we using more? And, you know, the alarm there was that the macrolides, as we can see there, you know, down here, we use erythromycin as our lab measure for azithromycin. And as you can see on the chart here, red and yellow is generally bad. So if you look, you know, down the column from erythromycin, we're seeing that the susceptibilities to it have been really taking a beating over the years, and it's not a really reliable antibiotic for in many cases. Oops. And so we took a little bit of a deeper dive into the data, and Dr. Vanstone from our program put together trying to combine the data that we had, again, from those G12 clinics, and if the physicians or nurse practitioners had included an indication in the order for that antibiotic, let's just look at those to see how we're doing with our azithromycin, amoxicillin, and our duration of therapy. Are we sticking a little bit closer to what we should be doing? And what we could find there, you'll see the red circles there. So amoxicillin in blue and azithromycin in orange. You could see 61 of the cases were that were seen and where an indication for sinusitis was documented. The majority of patients got azithromycin and amoxicillin in blue and amoxiclav in light blue under it. That would be more of the preferred therapy unless you have a severe penicillin allergy. But we can see from those that we are using more azithromycin. And from there, this looks a little bit busy, but, you know, outlined here in the top red arrow marker there, that's our amoxicillin and our sort of average duration of therapy. And we were very similar to the American data, sitting at 10 days of therapy for amoxicillin. When it comes to azithromycin, we're sitting at 5 days. But so which fits with the other data that we are seeing, but we're still not doing a good job of adhering to the guidelines and shortening our duration of therapy when we need to. Because as we could see with those guidelines, the only time we really need to extend that therapy is the more complicated patients. So unless we're seeing all complicated patients or all patients with penicillin allergies, the data isn't looking great for us here. And the analogy I like to give is that, well, 1984 is around the time that Zithromax came out, and it's also close to the time that the Pontiac Fiero came out. Anyone remember the Fiero? No, you guys don't remember that? I thought when I was in '84, I thought this was the coolest car ever. It was like a fancy sports car that was affordable, maybe. And it's kind of like Zithromax. It's a sort of a fancied up version of erythromycin. There's nothing much better about it. It's kind of handy that it's once a day. It's only 5 days, which a lot of people thought was better. But it isn't necessarily that good. And as we look, how has Zithromax aged over these years? Zithromax has aged terribly. We see these more and more resistance to it. It's not looking good. And just like the Fiero, if you were driving around that Fiero today, still thinking you were that cool guy from '84, it's kind of like still prescribing azithromycin for the last 20 plus years, thinking it's still that same drug. So, why is Hall & Oates on there? They were the guy on the original picture. They've aged as well, just as Zithromax has. So please don't be that guy. So going from there, for community prescribers, a big focus on our program is providing those supports. So we do have a good website. You can see it there at the top, and you can, as you toggle through, there's a number of different things you can look at. We try to make it a website that can be accessed and utilized by both prescribers or healthcare practitioners, but also the public, because there are also some educational tools, short videos on there. We have links to our viral prescription pad and different educational material. We have just a basic pamphlet on what is antimicrobial resistance and what does it mean for you. When we have some that have gone out to both clinics and our emergency on upper respiratory tract infections, as well as one focused on pediatrics, because that's a common presentation that's seen. And, you know, again, anecdotally, from talking to these physicians, they do find them very beneficial. And also, you know, seeing patients who have been holding onto that viral prescription pad, I think, you know, in talking with them afterwards, there is some comfort in getting a bit of a plan out of that, as opposed to just, you know, being told you've got a viral illness. I know you've had antibiotics every other time, but I'm not going to do it this time because it's bad now. And I think a lot of the message is lost on patients that way, but having some backup information can help get that, the education sort of hammered home. And so resources again, here's just a quick plug for our antibiogram. As you could see from, you know, our antibiogram is a handy tool. We're using it to look at how strep pneumoniae resistance is changing over time, and you can see it clearly happening. The 2017 update is coming out right away. So in Regina, we have that downloadable on Android or iPhone. And we can also help you out the program if that's something you want to set up. We can help you set it up so you have it there as a tool. And then lastly, is for resources, we also have these on our website, but RX Files is a great resource for community-based prescribers who want to look for just a really solid evidence-based resource to go to that guides you through when it comes to common infections. Which are the best antibiotics to go to, how to avoid using antibiotics if it's viral, symptomatic management, and all that sort of piece. So I encourage you guys to check out what RX Files has as well. The same viral prescription pad, they've expanded a copy into 12 different languages, I believe, as well. So for people who have other languages, it's a great tool as well. So lastly, I just kind of want to wrap things up with if you have this view that, you know, antibiotics, I think for a long time were seen as a somewhat benign medication. We could add it on just in case. But more and more, we're seeing there is clear harm when we're prescribing these, and especially when we're over-prescribing them, driving antibiotic causing adverse events as well as drug interactions. So we need to change the way that we think about antibiotics as just we're treating the patient to something that we're looking at as a societal drug. Because when we use antibiotics, we're not just affecting that patient, we're affecting the microbiome of people around that patient and the population that's there. So we have to look at, you know, each dose we use is one less potentially for society. All right. So very lastly, you know, I just want to say, where do we go from here? So as far as working together and continuing to engage with community prescribers, we're asking them to contact us, and we're always open to coming to talk to people, to doing presentations, or figuring out, you know, if you want us to collect your metrics to feed that back to you and you think that would be valuable for your clinic, you know, talk to us and we can set that up. And as far as the tools that we've had developed, the viral prescription pad, the educational tools, we also need to see, are these actually helpful? And we hear, again, anecdotally from different people that, yeah, they're great and I find them so helpful. And we hear from other people, yeah, I never even use them. I just don't bother. So we have to figure out, well, what is it about the tool that either makes you want to use it or not use it, or are we missing something? What more do you need to be able to do your job the best that you can? And again, so we just want to expand our metrics from our G12 clinics, going broader and hopefully as our program continues to build and we're working on things provincially, we can hopefully get some provincial metrics and look at things more broadly. So just from there, I'll open it up to questions. I imagine we have a huge crowd here at the Pasco, so I'll save your guys' questions for the end. But if there's any of the distant sites have questions? And Jason, are you logging into? Okay, so we got Jason looking at WebEx for any questions.
Hey, Casey, it's Jackie at the General.
Hi, Jackie.
That chart that you have.
Sorry, Jackie, you're getting cut off there.
Sorry, technical malfunction here. That chart you showed earlier, and I might have just missed it, that had a list of indications that shorter durations of antibiotics were appropriate for. Where was that from again, or how do you access that?
I'll give you the, I think I included the reference in this, but it's Spellberg B, the new antibiotic mantra, shorter is better. Even if you just Google new antibiotic mantra, shorter is better, it brings up that article. And, you know, the interesting thing about it is it's not really bringing up a lot of new data or research. This is all stuff that's been around for quite a while and just putting it together. But we're just not kind of taking that message that shorter courses can work just as well with less harm. And it's something we need to focus on.
Thank you.
Thanks, Jackie. Any other questions?
Hi, Casey. It's Linda. Thanks for the presentation and the update of what you guys been up to. Regarding your G12 group, I'm just curious, within the group, are you finding disparities? And is that because I assume you give it back to them in relationship to their coworkers?
That's right. Thanks, Linda. Yeah, you know, feeding back that data, there's definitely disparities. And unfortunately, the quality of the data that we can give back right now is limited. So we have information on duration of therapy, what specific antibiotic you're prescribing, which practitioner prescribed it. But a key piece that we're missing and we're trying to include is indication. So of the numbers that I looked at for the acute sinusitis in Regina, that was a very small subset of a huge data set. And we're trying to work together with Dr. Hanzia and different physicians to figure out how can we make this more of a priority to attach that indication to the antibiotic, because that gives us so much more information to play with. The second piece that we added in was actually a spectrum score, which gauges the how broad or narrow an antibiotic is. And if we look at that same data and we compare prescribers based on how many, so the sheer volume of prescriptions, as well as a spectrum score, we can also kind of differentiate into some quartiles who's prescribing more and who's prescribing more broadly, and maybe using that as an impetus to potentially target those physicians. But we're still looking at continuing to refine that data to give back to the physicians.
Right. Thank you. That makes sense, but I like your second approach because I think it'd be interesting within a group you should relatively be seeing the same type of population. So to look at what type of antibiotics and how much per prescriber, that's probably a good way to go about it.
Yeah, and we found that process quite beneficial. As an example, even with the pediatrics group here in Regina, we began meeting with them shortly after we started the program, feeding back their data in a very similar manner. And it was interesting seeing the conversations that grew just from that, because the physicians could see, why am I doing 3 times as much Pip/Tazo as this guy or twice as much as everyone else? And why am I always more IV than PO? What are my colleagues doing? So it started a lot of conversations that we hope will get more standardization in that approach to how to treat the infectious disease. Any other questions? Anyone here? No questions at the back? Well, I'd like to thank everyone here for coming. I'd like to thank everyone for tuning in as well, and hopefully catch you next month at our next education meeting. So thanks, and I'll sign off from there.